Hi, Miss Nikki here. Welcome to Chapter 8. If you've had a chance to look at Chapter 8 in the textbook, you'll see that the majority of the material is lab material. There's a few extra items that we need to know about. Again, just follow your learning objectives for this chapter and you'll be fine. This video is part 1 and we're going to focus on the axial skeleton. The next video will be part 2 and we'll focus on the appendicular skeleton. We break the skeletal system into two separate sections. So we have the axial and the appendicular skeleton. You can read here the axial, we're talking about the skull, that's both cranial and facial, the vertebrae and the thoracic cage, which we will learn is the sternum and the ribs. Remember, skull is facial and cranial bones. So basically, if I gave you a list in a test and I said which one of these is not an axial skeleton bone, you could pick them out. So you should know which bones make up the axial. And then which bones make up the appendicular. So we will subdivide the appendicular into the pectoral girdle, right? And so this holds your upper limbs in place. And then the pelvic girdle, which holds your lower limbs in place. So think of the pectoral girdle as the scapula, the clavicle, your humerus, radius, ulna, all the bones of your wrist and your hand. And the pelvic girdle is going to be your hip bone or coxal bone or os coxa. There's lots of names for the hip. And then all of the lower limbs. So that would be the femur, the tibia, the fibula, all of the ankle, tarsal bones, and bones of the foot. Nice color coding here. You can see the axial, and then you can see the appendicular is hanging off of the axial. There's also some interesting points to make here about where the axial and appendicular bones are articulated or joined together. So we're going to see here where the hip comes in contact with the sacrum. That's where one area where the axial and appendicular meet. And then the clavicle is here, and the clavicle attaches to the scapula and then here to the manubrium. So that's another kind of articulation point between the axial and appendicular skeleton. Nice little table here to show you the bone markings. I wouldn't try to just memorize all of these. As you're learning the features on a bone, like epicondyle, that's a feature of this bone, you'll kind of understand what they mean or what they're trying to describe. One that's really important that we see all the time is foramen. This is a hole. So if you see some sort of passageway through a bone, you're always going to have that word foramen. Another one, we'll see the spine, we'll see a line, we'll see fossa. This is, again, pretty prevalent, a shallow depression, so like a little indentation or pocket. Condyle you'll see, large, smooth, rounded. And one of the things to note is, why do we have all of these projections and bone markings, as they're called? So you see here on the femur, we have this trochanter, and there's a greater and lesser trochanter that we'll learn more about. But think about the muscles that have to hang on the femur. So this is the back side. This is a posterior view of the femur. And here I'm going to have hamstrings. And we have 3 really large hamstring muscles that are attached at these bone marking sites. So if bones were completely smooth, we'd have a hard time attaching muscles to get the desired action of that muscle. So you're going to see lots of pits and grooves and rough spots and smooth spots and holes. Here we've got nerve endings coming down from our spinal cord, but they have to get into our legs. So how are we going to pass nerve endings through solid bone? We're not. We're going to have a hole there. We're going to have a foramen. The skull we subdivide into cranial bones and facial bones. So cranial bones, you're going to touch the brain. Facial bones obviously make up the face. Let's just review some of the cavities. Here we have the cranial cavity where our brain is going to be located. We have orbital for our eye. We have nasal cavity, and we have the oral cavity. Then they outline the sinuses. Just a quick thought on the sinuses. The reason that we have these sinus cavities is that it makes our head a little bit lighter. So if this was all compact bone, your face would be in more of a downward trajectory than able to lift up unless you had serious neck muscles, and then that would interfere with the flexibility of our head and our neck. So there's always a little bit of give and take. We want to have compact bone to keep important organs safe, but sometimes we will have less bone if we need more flexibility. I'll go through the cranial bones and then I'll go through the facial bones. It's nice that all of these images are color-coded, but don't rely on this solely. When you first start looking at these PowerPoints, it's nice to have the colored images and you can see where the bone starts and stops. But you'll notice on the practice quiz, it's from APR, and you'll have images that are true skeletal images where they're not color-coded. So kind of start with the color coding, but then make sure that you do your APR and that you can recognize the bone if everything is the same color. What's nice here is we have our frontal bone. We can see on the sides here, temporal, and we have another image where you can see that a little bit better. You have parietal here and here. So frontal, parietal, temporal. Then we have sphenoid and ethmoid. So sphenoid is here in purple, and the ethmoid is back here. It's kind of hard to see. There's only a tiny little bit that's sticking out, but you can see the majority of the ethmoid here. So it's kind of in two places, and we'll remove some of the bones so that you can see this a little bit better. So we have, for cranial bones, we have our frontal, we have our temporal, we have our sphenoid, we have our ethmoid, we have our parietal, and then on the back side we're going to have our occipital. This lateral view, we can see the parietal. There's one of those. We can only see one. There's another one on the other side. Here's one of the temporal bones. Again, remember there's one on the other side. Then we have one occipital bone. We have one frontal bone. And then we have two, the ethmoid and the sphenoid. And there's a better internal view coming up in just a second. So here's part of the sphenoid, and here's part of the ethmoid. Nice internal view here. You can see that we've done a transverse section. And here is the sphenoid. Some people say it's bat-shaped, bird-shaped. And then we can see part of the ethmoid that sticks up from the top. I'm going to show you another image, but basically the kind of ethmoid shape is about like this. It's a little bit more complicated. I'm kind of being very simplistic here. So the top section here is what we can see. When we look into the nasal cavity, we can see these little pieces, these distal portions of the ethmoid projecting into the nasal cavity. Another nice image of the internal bones, you can see, here's the part that we just looked at, the top section of the ethmoid. And the ethmoid kind of comes down, and you can see some of the ethmoid in the superior portion of the nasal cavity. Here we can see that winged structure that is the sphenoid. Now let's go back and look at some of the frontal bone features. So here we have a supraorbital margin, superior. Orbital tells you the cavity. Foramen, there's also a hole. Blood vessels are going to be able to innervate the facial muscles here. So think about, there are different ways that this could possibly be worded. I try to be pretty lenient. Whatever's in APR is probably your best bet, but I've heard this called supraorbital margin with notch, because there's a little notch right there where the foramen is. So there's several ways to kind of word this. Check with the quiz and check with APR and you'll be good to go. The parietal bones do not have any features that we're going to worry about right now. We can see here with the occipital bone, we do have one feature that we need from this image to look at, and that's the foramen magnum. This is where your brain stem is going to exit and become your spinal cord. With the sphenoid, you can see that there's a lesser and a greater wing. So this is the lesser and this is the greater, but the entire structure is the sphenoid. The sphenoid also has this sella turcica, it's basically a cup-shaped bony structure that protects the pituitary. That's why in this textbook it calls it the hypophyseal fossa. That's another name for pituitary. In our lab book, we just call this entire structure sella turcica, which is fine. You can use that terminology. The other thing to notice here is the top of the ethmoid. So the ethmoid has something called a crista galli and a cribriform plate. So the plate, cribriform plate, is the bottom structure, and it's kind of hard to see in this image, but the crista galli sits up. It's kind of looks like a shark's fin, but a real tiny one, right? It's a bony projection. And when we talk about the meningeal layers of the brain, we'll come back and mention the crista galli. The cribriform plate has tiny little holes, and this is how your olfactory nerve gets to your brain so you can register things that you're smelling. Here's a nice image from the underside or inferior view, and you can see here the occipital condyles. Remember, condyle was a rounded structure. So this is a little deceiving. They're kind of this rounded, slightly rounded structure. And this is where your first vertebrae are going to sit. So this is the articulation point for vertebrae number 1. This is probably a better image of your crista galli. And the cribriform plate would be here at the base. Then the ethmoid forms this perpendicular plate that's going to come out and be visible here in the superior portion of the nasal cavity. In this image, we can see these 3 projections of the ethmoid coming into the nasal cavity. So remember, the ethmoid is continuing back here. We have the perpendicular plate, and then up at the top we have the cribriform plate, and then we have that crista galli. So you can really only see parts of the ethmoid unless you removed or did a frontal section of the skull. One of the interesting factors are the superior and middle nasal conchae. Both of these, so this bone and this bone, are considered part of the ethmoid. They're all connected. This part of the ethmoid touches the brain, so it's a cranial bone. And then this one, the inferior nasal conchae, do you see how it's kind of separated? It comes in contact with other bones, but it's not part of the ethmoid. So this inferior nasal conchae is a facial bone that we'll talk about in just a second. So kind of strange. The superior and middle nasal conchae are part of the ethmoid, and they are a cranial bone. The inferior nasal conchae is a separate bone, and it is a facial bone. Here we can look at the temporal bone in yellow, and we can look at some of the features. So we have the external acoustic meatus. So this is the opening for your ear. We have the styloid process. We're going to have neck muscles attached to the styloid process. Mastoid process, this kind of bumpy projection here, is going to attach one of your neck muscles, probably most prominent, your sternocleidomastoideus. We also have over here this bar or bridge that goes to one of your facial bones. So this is a facial bone that we'll talk about in just a second, but there's kind of this bridge from the temporal bone to your cheekbone. And so it's called the zygomatic process of the temporal bone. We need to look at the inferior view of the temporal bone to see the rest of the features. Here we have this nice fossa, and it's called the mandibular fossa. This is where your jaw or your mandible is going to fit or articulate into your temporal bone. We also see a jugular foramen. That's the venous drainage from the head carrying deoxygenated blood. And then we have the carotid foramen or carotid canal, which is carrying oxygenated blood to the brain. Now let's move on to facial bones. There's several that we don't have to learn any special features, you just have to be able to identify those bones. So we're going to start out here with our zygomatic, which is our cheekbone, right? So that's zygomatic. Then here we have a tiny little bone called the lacrimal bone. You have a lacrimal gland that has a duct system to release lubricant for the eye and sometimes tears. So the lacrimal bone is this tiny little green bone. It's named because the lacrimal duct crosses it. Here we have the nasal bone. This makes up the bridge of your nose. We've already discussed the inferior nasal concha. Here we have the vomer, and the vomer meets or joins the perpendicular plate of the ethmoid and the maxilla. So then all of this, your upper jaw is your maxilla, your lower jaw is your mandible. And the one bone, facial bone that we can't see is underneath, and it's called the palatine bone. Nice lateral view here. We can see the zygomatic, we can see the lacrimal, the upper portion of the maxilla, and then it comes down to form your upper jaw, and then the nasal bone. We do need to talk a little bit more about the maxilla and mandible. There's several features that we need to look at. So again, I urge you to go to APR and use the APR Connect software to look at each of these, and it'll highlight every bone feature that we need to know for you. This image is kind of hiding a few areas that I would like to focus on, but I'm going to tell you to go to APR. So in the lab book, we mentioned this section. This is the coronoid. You can see here the ramus. This is the ramus of the mandible. This is the mandibular angle. And then here what's hidden, or that's hard to see, is the mandibular condyle. The mandibular condyle is a rounded top section of the mandible that fits into that mandibular fossa. And we'll see this when we get to articulation chapter. So remember your TMJ joint if you do. So your temporomandibular joint, this is where your mandible and your temporal bone meet. So the mandibular condyle is going to fit into the mandibular fossa of the temporal bone. We also have a mental foramen. Sometimes this is hard for us. We think of mental as head, but mental actually means chin. And then there's also inside here, there's another foramen, and that's the mandibular foramen. So again, I urge you to go and look at APR for a better view. These here, we have it in both the maxilla and the mandible. These are alveolar processes. This is where the teeth fit into the bone. So we need to focus on the maxilla just for a second, and we can see the alveolar process here just as we saw in the mandible. There's also an infraorbital foramen, so under the eye hole, just like we had a supraorbital foramen above the eye hole. Also remember back here we had maxillary sinuses, so behind, if we were to do a frontal section and remove some of this, we could see the maxillary sinus, and there was a previous PowerPoint slide that did a good job of showing that. The other thing to think about is why we have all of these foramen. Remember that we have to be able to feed nerves and blood to all of the facial muscles that are sitting on top of all of these bones. One bone that we haven't covered yet is the palatine bone. The palatine is a facial bone that makes up a third of the roof of your mouth. The rest of this is maxilla. And so they call this area the palatine process of the maxilla. So really your hard palate, or the bony part of the roof of your mouth, is made up of maxilla and palatine bones. I think it's worthy to look at this image and note the complexity of the orbital cavity. You can see that several cranial bones, so frontal, sphenoid, right? Several cranial bones and several facial bones, zygomatic, maxilla, palatine, lacrimal, they all create the orbital cavity that we see. So one of the reasons I mention this is you could imagine if someone gets punched in the face, imagine all of the bones that they could break or fracture from one punch. Nice image from your textbook just to show you how the brain fills the volume of the cranial cavity. Another nice image for you to see the sinus cavities. We can see why these are called the frontal sinuses, because this is your frontal bone. And these are the maxillary sinuses, because this is your maxilla. And so just another nice image from the textbook. The last list of bones associated with the skull are the Auditoryossicles. These are teeny tiny ear bones. We're going to come back and talk about these when we do special senses. But I do want you to realize they are bones. So we have the malleus, the incus, and the stapes. The fetal skull is a little bit different than adolescent or adult skull in that they have fontanelles. You can see the 4 of them here, the mastoid, the posterior, the anterior, and the sphenoidal. You can imagine how having this softer tissue, this more cartilage-like tissue, would allow for the skull to be compressed a little bit as it's making its way out of the vaginal canal. Usually when children are born, the anterior fontanelle has not completely closed yet. Usually these have closed. So this is why you have to be careful with the baby's head, especially when they're newborn. We do have sex differences in the skull due to different hormone release. So remember, females estrogen, males testosterone, and that testosterone seems to make the male features a little bit more blocky. So we kind of have this blocky cranial mass or cranial vault. For the frontal bone, the supraorbital margin with notch is a little bit blockier. You can see that the zygomatic process is a little bit blockier, as well as the mandible. And with the females, we have kind of this more rounded appearance in all of those areas. Finally, we get to move away from the skull and talk about the hyoid bone. You can see in this enlarged image that there are some special features, and they're going to allow for neck muscles to hang from this bone. You can see that it is superior to the larynx and the trachea. This bone is interesting because it does not articulate with another bone. So this is the only bone in the human body that does not articulate to another bone. And what's interesting, if you watch crime dramas, you know that if there's a fracture to the hyoid, it usually indicates strangulation. So think about it, if you have enough force here pushing, it'll fracture the hyoid bone if you're collapsing the larynx and the trachea so that the person can't get air. Before we look at the individual vertebrae, I just wanted to go over that we have cervical vertebrae. There are 7. We have 12 thoracic, 1 for each rib. We have 5 lumbar. Most of us think lower back, right? Then we have a sacrum and a coccyx. Most of us would think of the coccyx as our tailbone. Before we move on to talk about vertebrae shape, I figured we would look at what normal looks like. So here's a normal spinal column. We can see here this curve, this rounded curve, and this rounded curve we're born with. Nice rounded curve. As a child starts to push up their upper body and tilt their head back, we start developing this secondary curve here in the cervical region. And then as a toddler learns how to walk and balance themselves, we develop this secondary curve here in the lumbar region. And there are some issues that can occur. We can have scoliosis, where the spine is not in alignment. We can have kyphosis, which this is a kind of a bending forward of the spinal cord. And then we can also have lordosis, sometimes called sway back. This is usually, it's common in pregnancy because you're carrying so much weight that your spinal cord kind of has to adjust to the weight that you're carrying. I guess you could also see it in individuals that are obese. Some common vertebral features that we need to look at before we move on to each individual vertebrae. They all have a spinous process, and this is going to be on the posterior side. They all have a body, which is on the anterior side. They all have a transverse process. Some of them are larger than others or modified in ways that we'll see. We have the vertebral foramen. And then you're going to have points of attachment where when you stack the vertebrae, these are the parts that are touching. So that's why they're called articular surfaces or facets. So you have a superior on the top, and then underneath you're going to have an inferior. Basically, these are just where the vertebrae articulate with each other. That's where they sit. This is a nice follow-on slide from the last chapter. We can see right here the inferior articular facet and the superior articular facet are the areas where they're touching. So this is lumbar vertebrae 3 and lumbar vertebrae 4, and you can see how the inferior and superior are touching each other. The other important part that we need to look at is this intervertebral foramen. When I stack two vertebrae on top of each other, not only do I have the articulation between the superior and inferior articular processes, I also create this hole, this between vertebrae hole, foramen. We're going to see spinal nerves come out. We should have seen this way back in chapter 1. So this is how spinal nerves exit to innervate the body at various levels. Now we move on to cervical vertebrae. And one of the differences with cervical vertebrae is that they have transverse foramen. They are going to have openings or holes in the transverse process. So you can always tell a cervical vertebrae if it has these transverse foramen because none of the other vertebrae have it. This is where your cranial nerves, the nerves from your brain, are going to exit. Another defining feature of cervical vertebrae, they have this split or bifid spinous process. Again, only seen in cervical vertebrae. Another reminder, go to APR and look at these bones. We need to talk about the atlas. This is C1. This is the very first vertebrae atlas that holds up your world. So remember, your occipital bone is here with your occipital condyles, and they're going to articulate to C1. You're holding up the world. Your world is your brain, right? It's your supercomputer. So the atlas is the very first vertebrae. We give it a special name. You can see it's a little modified, right? You cannot see as much the pronounced bifid spinous process as all cervical vertebrae are supposed to have, but you do see the holes or the openings called transverse foramen in the transverse process. So it does look a little bit different. The body is not quite as large, and we see a much larger vertebral foramen. Now we look at C2, or cervical vertebrae number 2, which is the axis. So sitting directly on top of the axis would be C1, the atlas. The axis is a little bit different. You can see here it has this kind of nub that sticks up, this dens, as we call it, dens process. We still have transverse foramen, and now we see kind of what we're used to, that bifid spinous process that's true of cervical vertebrae. Now we see a more defined body and kind of a normal sized vertebral foramen. Nice image here with the atlas and the axis. So you can see the atlas is superior. It sits on top of the axis. So why did we call it the axis? This dens, this special feature of the axis, serves as a point of rotation. We have a ligament here that's holding the two cervical vertebrae together. So the transverse ligament holds the atlas and the axis together. What's happening is this ligament gives you the ability to twist your head. You can twist your atlas to say no. You can also raise your atlas up or down to nod yes. So this is a great arrangement that allows us to have flexibility and to move our head in various ways. On to thoracic vertebrae. So we have 12 thoracic vertebrae. Each thoracic vertebrae is attached to a rib. We can see a body, we can see the vertebral foramen, we can see the transverse process. See how we do not have a hole anymore, right? The transverse foramen is gone. That's only in cervical. And then we see our spinous process. And again, it's a normal spinous process. It doesn't have that bifid or that split. Another thing to notice are the spinous processes angled down in the thoracic vertebrae, and that should make sense. They're not sticking straight out, right? It'd be hard to lay down if your spinous processes of your thoracic vertebrae were to jut straight out, right? Now we move on to lumbar vertebrae. One thing to notice is how much larger the body is. We're supporting weight, right? As we go down the spinal column, the bodies of the vertebrae become larger and larger. And then we have this very pronounced large spinous process, and it is jutting straight out. It's supporting all of the weight from above. Lastly, we cover the sacrum and the coccyx. So the fifth lumbar vertebrae would articulate on this superior aspect of the sacrum. There are 5 sacral bones that are fused together to create this kind of irregular structure. And what we really need to focus on, 1, the sacral foramina. So foramina is plural, so these openings. Basically, this is going to allow nerves to continue into the pelvic cavity and into the gluteal region. Next, we have the coccyx. This is made up of 4 bones. The other thing that I want to mention is this articular surface here and here. So they just list it as articular surface. We usually call it the sacroiliac joint. So for the sacrum, and then the hip bone is going to be here, but specifically the section of the coxal bone that articulates to the sacrum is called the ilium. So that's why it's the sacroiliac joint. Moving on to the thoracic cage, we can look here at the sternum and see that it's composed of 3 different sections. So we have the manubrium, we have the body, and the xiphoid or xiphoid process. When we talk about the pectoral girdle, when we get to appendicular, we're going to see that the clavicle attaches here at the manubrium. On this side, we've listed the ribs. We can see that ribs attach posteriorly to vertebrae. So here's T1 through T12. On the anterior side, we have costal cartilage that then attaches to the sternum. And remember, your lungs are going to inflate and deflate. So we have to have that cartilage there to allow for that expansion and contraction. True ribs are ribs 1 through 7 because they have their own cartilage connection to the sternum. False ribs are 8 through 12. 8, 9, and 10 all piggyback onto 7s. So they're kind of going for a free ride. 11 and 12 stop short. They do not come to the sternum. 11 and 12 are really to protect the kidneys. So they don't need to come up to the sternum. Also, if they did, we'd have some flexibility issues at the waist. Last slide here, we can see the rib anatomy and the articulation with the thoracic vertebrae. It's pretty complex and there's lots of additional features here. I really want you to be able to see that there is a neck, an angle, and a shaft, and that the tubercle is where the rib articulates with the transverse process of the vertebrae. We also have articulation here at the head. So the head of the rib is going to articulate with a costal facet that's on the body portion of the vertebrae. So next lecture, I'll talk about all the appendicular bones and all of their features.